Today I am sharing a video on Wilson's disease. Wilson's disease is an inborn error of metabolism in which there occurs a accumulation of copper, and this copper mainly accumulates in liver, brain and cornea. The gene for Wilson's disease is ATP7B, which was mapped to chromosome 13. The presentation of Wilson's disease can be, as we can see, that accumulation of copper is occurring in the liver, brain and cornea. So basically, if there is hepatic accumulation, which occurs mainly in the early childhood, the presentation may be in the form of maybe asymptomatic hepatomegaly, acute liver disease, chronic liver disease, or portal hypertension. While neurological disease mainly presents in adolescents and adults, present as clumsiness, speech difficulties, scholastic deterioration, behavioral problem, convulsions, and chorioathetosis. Now, as we can see, the clinical features can be hepatic presentation may be there or neurological presentation may be there. Uh, Now, how to investigate a child with a Wilson's disease? The very first thing we need to do is serum ceruloplasmin. If it is less than 20 milligram per deciliter, then if it's a Wilson's disease, there will be excessive excretion of the copper. So 24-hour urinary copper excretion will be more than 100 microgram per day. Hepatic copper, for that we need to do the liver biopsy. And if it is more than 250 microgram per gram dry weight of the liver, or as we were aware that accumulation of copper is also occurring in the cornea, it will lead to the formation of the ring that is called Kayser-Fisher ring. If KF ring is present, then also it's diagnostic for Wilson's disease. Uh, it is present in 96% of neurological presentation, 60% in hepatic, and asymptomatic 10 to 20% we may get the KF rings. Now, mutational analysis, we don't do commonly mutation analysis because more than 200 mutations are known for the Wilson's disease, and but it can be used for screening the family members who are asymptomatic. As so, we can remember this lab investigation with the help of 20, 100, and 250. 20 serum ceruloplasmin less than 20, excretion of copper in urine more than 100 microgram per day, or hepatic copper more than 250 microgram per gram. So 20, 100, 250 is a figure we need to remember. Then we have how to make the diagnosis of Wilson's disease. Any two of the following should be present. First is low ceruloplasmin. Another one is high urinary copper. Another thing is KF ring. But if we are doubtful, then we may go for the liver biopsy and do the hepatic copper. Now, how to treat a child who is coming with a Wilson's disease? Every problem is due to the copper because copper is accumulating in liver, brain, cornea. So it is affecting the normal function of the liver. It is affecting the normal function of the brain. So the first thing we need to do is we need to curb the foods which contain high copper, like nuts, meats, chocolates. We need to avoid that. Second thing we need is induction therapy. For induction therapy, we need to get the aggressive, copper drainage out of the body. So induction therapy is given for 4 to 6 months. It aims at reducing the copper to the subtoxic levels. So we need to make that copper excretion should be less than 500 microgram per day, and non-ceruloplasmin copper should be less than 25 milligram per deciliter. Drugs used are penicillamine and triantine. Now, penicillamine is a very good drug for excretion of copper. It induces rapid excretion of the copper, making it fall like hell during the first days. But the problem is D-penicillamine is associated with many side effects like skin rash, bone marrow depression, nephrotic syndrome, neurological problems, and all that. Alternative to that chelating agent, penicillamine, is triantine. Triantine is a good drug. Penicillamine and triantine both are used in the dose of 20 milligram per kg per day in two divided doses. Now, another drug is ammonium tetrathiomolybdate, but the problem is it is not easily available in India, and it is mainly used for neurological manifestation of the Wilson's disease. Like we have seen that neurological manifestation can be in the form of behavioral problem, scholastic deterioration, speech difficulty, convulsion, chorioathetoid movements, dystonia, all that can be present. Now, maintenance therapy. So once you reduce the copper to the subtoxic levels, another thing, you maintain that copper levels to the low levels. So slightly negative copper balance is required in maintenance therapy. For that, we may use penicillamine, triantine, and we may also use a zinc. अब जिंक हमारे पास एसिटेट, सल्फेट, ग्लूकोनेट सब फॉर्म से अवेलेबल होता है. जिंक वर्क करता है by inducing the intestinal cell metallothionein, which binds the copper to form the mercaptides. So, zinc is also a very good drug which can be used in the maintenance therapy, but it leads to slow excretion of the copper. Then another thing, if we have decompensated cirrhosis or the child is in acute liver failure, then we may need liver transplantation as the only option available for management of the Wilson's disease. Thank you.